Bismillah ar-Rahman ar-Rahim. Assalamu alaikum, everybody. I hope the voice is clear for everyone. I'm Dr. Philby, consultant pediatric pulmonology and sleep medicine in King Saud University Medical City in Riyadh. I would like to welcome you to this session, which is a part of the e-learning series organized by the Saudi Pediatric Pulmonary Association, led by Dr. Adil Harbi and other colleagues, as a part of the initiative in the memory of Dr. Mohammed Albalawi, Allah yarhamha wa yaskinha al-firdaus al-a'la. I would like to thank them for giving me the chance to give this talk with my colleague, Dr. Mohammed Albalawi, who is a consultant pediatric pulmonology and sleep medicine in King Faisal Specialist Hospital and Research Center. I'll be talking about the fascinating part of our lives during which we spend sleeping. I'll present the normal part of it and how to assess it. Then Dr. Albalawi will talk to you about the abnormalities and disorders that can happen while we're sleeping and how to diagnose and manage them. So I hope you will enjoy and benefit from this talk. And please, if you have any questions, post it in the Q&A box and we will try to answer at the end of the lecture. So Bismillah, I'll start. Okay, so what is sleep? Sleep is a naturally recurring state in all beings. And in the coming few slides, I'll go over what is sleep and why do we sleep, how and when do we sleep, and what happens to us while we are sleeping. So what is sleep? Sleep is a state between quiet wakefulness and coma. In quiet wakefulness, you are aware of what's around you, what's happening, and you can respond to any stimuli. In coma, you are deeply your consciousness is deeply affected, and sleep is a state that falls in between those two. During the state, you have reduced or lacking consciousness, relatively suspended sensory activity, and inactivity of nearly all voluntary muscles. However, this state is easily reversible. So if anybody calls you or you hear any sound or shakes you or something, you can easily go back to your full awareness and consciousness. Why do we sleep? Why is it important? Sleep is important for survival in general. As a general concept, we can think of it as the time required by our bodies and organs to recharge and to restore its energy so that these organs can have better and sustained function. As an example for our brains, sleep is very important to improve our learning, to have better recall of information and more retention of the thoughts. It's important to have clear thinking and improve our cognition and to have better state of awareness. For the heart, which is the most important muscle in the body, again, this quiet time is very important to strengthen the muscle of the heart. It has been linked with reduced risk of cardiac arrest, and it improves the beat rhythm of the heart. Also, sleep has been found to be very important in regulating the pancreatic function and the insulin regulation and the glucose levels in our blood. And it has been proven to decrease the risk of developing type 2 diabetes mellitus. Also, having good sleep lowers the risk of having accidents as it improves your motor coordination and it makes you more alert while driving. And during these days, while everyone is asking about how to protect ourselves from infection and how to improve our immune system, sleep is very important as it improves and strengthens our immunity. It makes the immune system faster in responding to different infections, and it improves the white blood cell function in fighting different germs. So it's important to have good time sleep. Also for the mental health, sleep is very essential. Those who sleep well are less likely to have an anxiety, depression, and their mental well-being is better than those who lack proper sleeping, whether in quantity or in quality. And again, another important issue maybe these days is the weight gain. Having good time sleep and good proper sleeping hours is very important in controlling our weight. And this is because the more you sleep or during your sleeping, you get more leptin, which is the hormone that makes us feel full. So if you take good sleep, you sleep properly, you don't feel as hungry as you do when you don't sleep well. Again, the ghrelin hormone, which makes us feel hungry and we're seeking food and want to eat, drops as if you get good time sleeping. So how do we sleep? How do we shift from the wakefulness and arousal state to the sleeping state? Maybe sometimes you would think that it's just simple, just like switching off the button of wakefulness and then you go to sleep. But in fact, sleep is a very dynamic process, and it is controlled by highly complex neuronal networks. And many physiological, metabolic, neurobehavioral processes are ongoing while you are sleeping. Simply speaking, and to make it very easy to understand, we have an arousal system in our brains, mainly formed by the reticular formation. In the brainstem, we have what is known as the ascending reticular activating system. Basically, these are a group of neurons that release different neurotransmitters. As we see here, the main 5 ones are acetylcholine, serotonin, norepinephrine, histamine, and dopamine. These are wake-promoting neurotransmitters that are released by this ARAS, and they affect the arousal areas in the brain, which are mainly the basal forebrain, the cerebral cortex, and the thalamus. So while this is happening, you are awake, you are aroused. What happens when we sleep is that there is a group of neurons known as the VLPO, which are the ventrolateral preoptic nucleus, found in the brain. This is sleep promoting or sleep activating neurons, which secrete the GABA reuptake inhibitors. So they increase the GABA levels in the brain and the ghrelin levels. And those two neurotransmitters actually inhibit the arousal system. Okay, so it's actually more complicated than this. Each of these neurotransmitters have multiple areas of action and multiple specific actions. But this is just a general concept that when this VLPO, which is the sleep activating neurons, are working, they release the neurotransmitters that inhibit the arousal system. So you shift from wakefulness to sleep. When does this happen? Now, this is how it happens, but when does the VLPO decide to work and release those neurotransmitters and shift us from wakefulness to sleep? This is actually very organized and coordinated, again, by 3 main processes. We have the circadian drive, and we have the homeostatic drive, and we have the adaptive drive. I'll try to explain them simply in this slide. So the first one is the circadian drive, and by that, I would like you to see the lower part of the slide, the circadian signal. This is basically the biological clock in our brain, okay, which is internally set at almost 24 hours. Okay, so this clock sends its signals in our brains, and it is, as you can see, low. This is the morning, 9 a.m., and then midday, and then this is the 9 p.m., and then this is the next morning. So you can see in the morning, once you are awake, the circadian signal is very low, and it increases as it is programmed like that. Its signals increases as the day go by until you reach the maximum level of it at the time where you should be falling asleep, and then it drops as you sleep. Now, what affects the circadian signal is mainly the light and darkness exposure. So as you see, when there is light exposure, the signals are low, and then as the darkness come on, the signals increase in their intensity. Also, the melatonin is another factor affecting the circadian signal, and it's, as you see, it is a sleep promoting hormone released in response to the exposure to darkness. So it starts secreting once we are at the beginning of the night, and it increases to reach its maximum around midnight, and then drops as we approach morning. So this is the lower part is known as the process C, or it is, as I said, the biological clock fixed in our brain. The second process that organize or control our sleeping is the homeostatic drive, which is represented here in the upper part, which is also known as process S, or the sleep depth or the sleep pressure. And as you see, when you wake up in the morning, sleep pressure is very low, which means you're not sleepy. You don't feel you want to sleep because you just woke up. As the day goes by, your sleep pressure increases until you reach a limit where you are very sleepy and you need to sleep. So your sleep pressure here is very high. So ideally, this should meet the maximum circadian signal, and then you fall asleep smoothly. As you sleep, the sleep pressure decreases again and drops until you reach the morning where you are again having very low sleep pressure and you wake up fresh. So ideally, for these two processes, ideally this is what we want, that you reach the maximum signals of the circadian rhythm with the maximum sleep pressure to have smooth entry to your sleep and to maintain your sleep very easily. The third process I mentioned, which is the adaptive, it means the surrounding and the environmental situation, the psychological situation that's happening around you while these processes are ongoing. For example, if you reach this point, okay, where you're supposed to fall asleep easily and smoothly and everything is good, your circadian or biological clock is set perfectly and your sleep pressure is very high. But for example, you're in the middle of an argument, or you're in the car, stuck in the traffic, or the environment or is not suitable for sleeping, you will not sleep. Also, if this happens and you just heard the bad news and you're very stressed and you're very anxious or something, again, it will not. So the adaptive drive means the situation around you, your psychological and environmental situation that will allow you. It must be ideal for sleeping so that you can go to sleep. Okay, so I hope it's clear. So you have the process C, process S, and then the adaptive all around this circumstances. I'd like to just stress on the importance of the light and dark exposure and melatonin release. As you see, it's very important and essential to understand that light is the main effector on the melatonin release. It reaches, melatonin is released by the pineal gland in our brains. And when there is light, you always see it is low and it drops whenever we're exposed to light. And I'm mentioning this particularly because this has a major effect, and this is why we always stress on not using any electronics or smartphones or iPads, especially for children in their bedrooms, because even if the lights are closed and the child is holding the screen in front of him, this light will affect the release of the melatonin, so it will be more difficult for this child to enter to sleep and to have more consolidated sleep throughout the night. Okay, so now after all this happened and we enter the sleep, what happens next? Once you enter sleep, it means you enter the first sleep cycle. I'll just explain here one sleep cycle in details to be aware of what's happening. So this stage, on this side, we can see the stages. We have the wakefulness, the R is the rapid eye movement sleep. And then we have the N1, 2, 3. These are all the non-rapid eye movement sleep, which is one stage, but it's the second part of the sleep, but it's divided into 3 parts. The difference between the REM and the non-REM is in the electrical activity in the brain and in the eye movement during those stages and in the muscle tone. So as you see now, when you enter from wakefulness to sleep, we usually enter to N1, and then you fluctuate for some time between N1 and wakefulness till you go to N2, and then you start fluctuating between N2 and N3 for some time until you settle on N3, which compose the major or the maximum duration during the non-REM. It's in N3, and we call it the deep sleep. And then you start going up again between N2 and N3, and then you end your cycle by a short period of the rapid eye movement sleep. And then this is the end of your sleep cycle. Sleep cycle duration, it's different depending on different ages. In children, it is shorter. But like an average, if we talk about adolescents and adults, each cycle takes around 75 to 90 minutes. So this is one cycle. What happens if you look at the overall the night? Here you are awake, and then you enter the first cycle, and then you start jumping from one cycle to another until it's morning time. What I want you to notice here is that, as you see in the early cycles at the first few hours of night, we can see that the majority of the cycle is composed of the non-REM sleep, and then there's a small portion of REM. And as you go by the night, the non-REM sleep becomes less and the REM sleep becomes more and longer. And this is very important in some disorders that Dr. Mohammed will talk about. So just keep this in mind. The first half of the night, it's predominantly non-REM sleep. The last half of the night or just before awakening, you have more REM sleep in your cycles. So what happens during this time while we're sleeping? We said there are many changes that are happening. I just summarized some of them here. Always think of the non-REM stage as the steady stage, the quiet, the organized part, and the REM is the stage that has a lot of variation. So the temperature is usually regulated at lower temperature, everything is also decreased, kind of slows down in the non-REM sleep. Sorry. While temperature regulates at ambient temperature in REM. The CNS activity is all depressed during the non-REM. The metabolic rate drops. The sympathetic nervous system activity is lower, while it is increased, and metabolic rate is increased in the REM sleep. A lot of hormones are released during our sleep. Some of them are increasing, some of them are decreasing, like the growth hormone, prolactin, insulin, renin, parathyroid hormone, and leptin increase, while the TSH and ghrelin decreases. Cardiovascular system, again, during non-REM, heart rate slows down, the blood pressure is in lower limits, lower normal, of course. And then in the REM sleep, we can see a lot of variation in the heart rate and in the blood pressure. The same thing happens for the respiratory system. The breathing is irregular in REM, while it's more regular with smaller tidal volumes in the non-REM sleep. In both situations, in both stages, we have higher upper airway resistance and diminished cough reflex. Again, for the GI system and the renal system, everything is slowed down. So lower motility and secretions in the GI system, and we have less production of urine, and it is highly concentrated. So now these are the major changes that happen in the sleep, and what does it mean that when we go to sleep. Now I'll talk about the assessment of sleep in children. And the main thing I want to stress on is that children are not small adults. Although they like to act like they're adults and they like to dress up like adults sometimes, but when we assist them for anything, and especially for sleep, we should not treat them as young adults. And this is because the childhood is the time where they are taught how to sleep. We teach them, it's a skill that we teach children. And it's the time where they develop different sleep behaviors. When we talk about the sleep cycles for children, they are shorter and they occur more frequently during the night. Children still require naps, and they're essential for them. If we were going to talk about the respiratory physiology, again, it's totally different in children than in adults. They have more compliant chest, they have smaller airways, and the childhood period is the time where we have rapid growth of tonsils and lymphoid tissue, and this will affect their breathing, mainly during sleep. Also, when we assess them, we have different parameters than those used in adults, as numbers and scales and so on. Children are more prone to have more frequent parasomnias and other behavioral disorders. So some disorders occur more in children and more than in adults. And very important to notice the effect of their sleep problem on the family, because the problem of the child will affect not only the child himself, not only the patient, probably one or both parents will be affected, if not more people in the house. So it's very important to assess the severity and effect of this issue on the family once you're planning your management. Sleep requirement. How many hours do we need to sleep every day? The average that we always hear as adults is 8 to 9 hours. You can see this is mainly for adolescents, young adults, and adults. And as you see in children, it's different depending on the age group. The younger you are, the more hours you need to sleep. So when you see newborns, they require 14 to 17 hours per day. The numbers in the dark blue is the average, and the light blue is the upper normal, lower normal. So you see, as the younger the baby is, the more hours he needs sleeping, and these numbers decrease as the child grows up until they reach the adult normals. So it's important to assess how many hours every child sleeps per day. So how do we evaluate them now? I'll go through those assessment methods briefly. First, we have the history from the patient or the parents if it's a young child. And it's very important, and we can get most of our information, we get it from this history. Physical examination, very important in certain diseases. We have some questionnaires and scales that we use, sleep study, sleep logs, actigraphy, and other assessment methods. So usually for the history, we go, what we've always been taught, that we go to the main complaint and we take the whole details about it, and then we go to the peripheries. In sleep history, it's quite different, as I think it's, and I'd like to do it in this way, that we go around the sleep situation of the child first, and then we go to the main problem. So there are 4 elements that we need to assess in every child, especially in the first visit, and before jumping to the main sleep complaint. Those elements are the wake sleep pattern, the sleep hygiene, sleep routine, and daytime function. And I'll explain each one briefly. For the wake sleep pattern, it basically means the timing. What is the schedule for this child? When does this child go to sleep at night? When does he wake up in the morning? If it's a child that goes to school, is there any difference between school days and weekends? We have to calculate the total hours of sleep per day that this child takes to see if they are matching the required for his or her age. We have to ask about the naps, the number of naps, the duration of each nap the child takes, and timing in the day. Does he take his naps in the afternoon around 12 to 1 or late in the day around 5 to 6 p.m.? And then we ask the time till the child falls asleep. Once the child is in bed, how long does it take him or her to fall asleep? And very important to ask mainly in very young children about the parental involvement during the bedtime. Does the parent stay in the room and sit on the bed, shake the baby, walk around carrying the baby, and all the behaviors that the parent do while the child is falling to sleep. The sleep hygiene means the environment. We assess the environment and the surrounding of the child and the place that he sleeps in, which means you ask about the bedroom that the child is sleeping in. Is it his own or is it shared? The bed, is it only for this child or not? Is it a comfortable bed? Is the house environment in general quiet or noisy? Is the room very dark, or they have like a night light, or they keep the door open for some light to enter the room? The room temperature, is it too cold or too hot? And if there's any toys and electronics in the bedroom, and safety measures, if there's risk for the child to fall off the bed or to have any safety issues in the room. Sleep routine, the third part we assess, and it basically means what does this child do the last 2-3 hours of his day before going to sleep? Is there a regular activity or schedule, like the child takes a shower and then eat dinner, read a book and go, or is it just random every day, something different? Is this period active in this child's life, like he's running and jumping all around the house, or it's a quiet time where he's choosing like board games or playing quietly? So this is important to know the situation before shifting from wakefulness to sleep. And the last item we assess is the daytime function, and it is of major importance because as you will see in the coming lecture, a lot of diseases, this is main criteria for the diagnosis, that the daytime must be affected. Daytime functioning. By this, of course, you go based on the age of the child and what is expected from him. So you can ask if he's playful, active, or he's sleepy all day. If the child is going to school, is his attendance affected by his sleepiness or his hyperactivity? His behaviors in school, his relationships with friends and teachers, the grades if he's attending school, if there's any problem with attention, concentration, or memory. And ask about after school life. Does this child participate in any activity, any gym, any other social activities, or he just comes back and he's sleepy? And so this gives you an impression about the general life of the patient. Once you went over all of these, this is just a summary of all the elements, and then we go to the main sleep complaint. And this is depending on the complaint that the child is coming with, there is certain history for each and every element of those. And I think you will hear more about this in the coming lecture. So after we have an idea, an impression about the sleeping style, the sleeping timing, the hours, the behaviors of this child, we go to the main complaint and we take all the details of this part. Next step is the physical examination. This is mainly maybe important in children presenting with sleep-related breathing disorders. I just want to say that there are some elements that are of major importance in our sleep examination. You have to look at the growth of the child. Makes a major difference if he is obese or he is failing to thrive. So you have to note that and check his BMI. Face, mouth, nose examination is very, very essential in sleep clinic. The face, you have to look at it in details, if there's any dysmorphology, any mid-face hypoplasia, micrognathia. The facial structure in general, you have to have an idea about it. Mouth examination also, you have to check the teeth, if there's any malocclusion or crowding. The tongue, if there's macroglossia, Mallampati score, to see how narrow the airway is, the mouth opening is. The palate, check if there's any cleft palate or high arched palate. And of course, tonsillar size, very important in children, as it is the main obstructing element for the airway. Nose, check if there's any septal deviation, nasal turbinate hypertrophy, or nasal polyps. Also, neck examination is very important in sleep clinic. You have to check if this child has short neck, such as in certain syndromes, if there is spasticity, such as in patients with CP, and if there are any masses. Then you go over the rest of the examination, chest, cardiovascular, and abdominal examination. Other mode of assessment we use is the modified Epworth score, which is a score for sleepiness. If the patient comes and they are complaining that the child is always sleepy, it's very important to do the modified Epworth score, which gives you an idea if this sleepiness is pathological or still within normal limits. So basically, there are about these are some questions. We usually give it to the parent, and we ask the mom to score, indicating the chance of dozing or sleeping of the child while he's doing these situations, while sitting and reading, watching TV, while in traffic, and so on. So, and then we calculate the whole score. If it's 10 or more, this means that this sleepiness is not normal. It is most likely pathological, and this child will need further workup. Then we have the sleep study, which is the gold standard for many disorders we have. It's actually a very comprehensive recording of all physiological changes that occur during sleep. We have mainly two parts that we record. We have the sleep stages and activity, and for this we use the brain EEG, eye movement, EOG, and muscle activity, EMG, and the camera that is recording. And for the cardiopulmonary monitoring, we use a lot of electrodes again and belts. We have the heart ECG, nasal airflow, nasal thermistor, microphone, chest belt, abdominal belt, end-tidal CO2, and oxygen saturation. So as you see, it's a very comprehensive study, and you can imagine how many leads and electrodes we have to hook on the patient, which is a very challenging process, especially when you're talking about a child, young age, or someone with mentally challenging disorder, and so on. So the key to, and you have to do all of this in one night. So the key to this is to have proper preparation for the child, which usually starts or recommended to be at least 2 weeks before the study. You have to make sure that the child is having a regular sleep schedule, that he sleeps at least 6 to 7 hours per night, because you don't want to bring the child to the sleep lab and do all the hookup and then end up with a child that's not sleeping in your lab. Very important to make sure that the child will sleep during that night as much as possible. Urine screen is recommended sometimes for adolescents, and very important to discuss all the medications used by the patient, because as you know, there are a lot of medications that affect sleep. All of these must be, if your child is on any of these medication, must be reviewed carefully, and depending on what's the aim of your study, stop those that need to be stopped. Of course, mainly for neurology medication and psychiatry, sometimes you have to contact the primary physician or treating physician just to discuss how you can decrease them or stop them before the study. Also, at the day of the study, you have to educate the parents that the patient should wake up early. They should avoid any naps during that day, avoid any caffeinated drinks or food. He should follow, before coming to the lab, they should follow the regular routine, wear something comfortable, bring whatever will help the child to fall asleep. If he has certain pillow or blanket or whatever, he can bring it with them to the lab. And we always encourage talking to the child, especially those older a little bit, and they can understand, to explain to them that we're going to have some stickers hanging on your head with leads and so on. Let them know what's happening, because it's a lot to just take the child and hook up everything and let him sleep, and it's too much on the child. So the more they know and they're aware of what's happening, the easier the sleep study will go. Pediatric lab, it's always recommended to have it child-friendly, very comfortable space, minimal distraction, make it as much as you can like the home child room. And this is the epoch what we get from the study. This is a 30-second screenshot, and you get like this for every 30 seconds throughout the night, and then it's scored according to certain guidelines, and you get finally the final the summary and the hypnogram for your study, and then you can interpret it according to your diagnosis. Next, we have sleep log, another method we use sometimes in the clinic, which is basically recording of the what's happening during the sleep time for over a week or two. We usually give them 2 or 3 pages like this. We have it translated in Arabic, and we have the English form. So basically, the child or the parent has to fill for each. You see here we have 7 days. For each day, they have to answer the question: when did they go to bed? When did they really sleep? How many times they woke up during the night? And how long they stayed awake? How did they feel next morning? And so on. This gives us again an idea, especially if we are assessing someone with insomnia. It gives you an idea about the pattern and what's going on throughout the week, not a one-day thing. It's the whole situation and the pattern of sleep for this child. And it helps you in reaching a final conclusion and diagnosis. And it is mainly important if you're planning to use actigraphy. And actigraphy is it's a Fitbit-like watch that we usually put on the non-dominant hand of the child. It basically records the light exposure and the activity of the child, and helps give you again an idea about what's happening. It's used mainly for insomnia cases. After they put it on for a week or two, and then you get a download which looks something like this. As you can see, it gives you the blue area is where there was minimum exposure to light and minimum activity. So when you look at the trend here, you can see that this child is going to sleep like a delayed phase every night later than the night before. And here we can see that this one is not having good amount of sleep during nighttime, but has frequent naps during the daytime. And the third pattern, you can see the sleeping is all over the place, so there is no really pattern in here. So this helps you again get an idea about the whole situation and the pattern of sleep that the child is having. Other things we might need sometimes sometimes we need to get some lab tests like blood gases, especially if we're expecting like CO2 retention during sleep, hemoglobin levels, genetic testing if there are some features of, or you're suspecting any syndromic problems. Frequently we need to consult neurology and neurosurgery, especially those where we suspect seizure or brainstem abnormalities, for those with central apneas and so on. ENT service, of course, we cannot manage many patients without them, because we frequently need TNA, adenotonsillectomy, and or sleep endoscopy. Endocrinology for those patients with obesity or narcolepsy. Dentistry, sometimes when we have malocclusion or some dental issues affecting the breathing while sleeping, and of course surgery for obese children. Maybe more of these details will be more clear for you when you hear the coming lecture by Dr. Mohammed Albalawi, as different diseases have different involvements. By this, I end my part, and I hope it was informative. And Dr. Mohammed Albalawi now will talk about the second part, which is the disorders and diseases you can face while you're sleeping. Thank you.
Okay. Thank you, Muna. It was really great and detailed lecture. I will try my best to finish all the sleep disorders now and what we left at this time. Okay, so we'll be skipping some parts that are not, that's talked already by Dr. Muna before. So we'll be focusing mainly on the sleep, pediatric sleep disorders. Prevalence, we just want to mention that sleep is a problem in kids, and it is prevalent as insufficient sleep reach up to 10% of the pediatric population, and its rates increase up to 33% in teens. Insomnia is between 10 to 30%. Obstructive sleep apnea as a syndrome itself between 1 to 4, and in addition to parasomnia, which range from 1 up to 50%, depending on what type of parasomnia we are talking about, in addition to limb movement disorder. The consequences, why we care, consequences of sleep insufficiency, as Dr. Muna mentioned about the physiology during sleep, there is changes in the hemodynamics, there is changes in the blood pressure. All these can lead to effects in the blood the body systems. So there is effect on the growth, as lots of hormones, as she talked, produced during sleep. So growth is affected. Neurocognitive ability, as we can see, lots of kids who are like put on multiple ADHD medications, which needs to be monitored, or we need to rule out any sleep disorder that might lead to this. Before cardiovascular system, the growth have been noted to be significantly improved after the improvement of the sleep. So we're talking here about the maxillofacial and the soft tissue changes that happens in the obstructive sleep apnea syndrome. On the right side, we have here the patients who are having obstructive sleep apnea. You can see here the soft palate and the uvula that is deep down, obscuring the airway. In addition, we have the retropharyngeal or the oropharyngeal airway that is significantly narrowed compared to patients who are having a normal airway. In addition, you have the distance between the hyoid bone and the mandible. One more thing is the mandible itself is significantly vertical in patients with sleep disordered breathing or upper airway obstruction. When you look at the angle or the retrognathia, you can see the retrognatic angle also is significantly different from patients who have sleep disordered breathing. Not to mention the adenoid, which is also enlarged in those patients. Tongue size is significantly different. So when we combine all these, in addition to structural factors like the muscular tone, which can be related to central nervous system disease or any other genetic or hormonal disease, all these might be contributing to the sleep disordered breathing, which at the end, which we make the possibility of passing the air more complicated and have a less chance of passing the air into the airway. Now going into the obstructive sleep apnea epidemiology, as we mentioned, the snoring in children is reaching up to 10% as a habitual snorer and intermittent up to 20%. Those who have documented obstructive sleep apnea have 1 to 4% of the preschool children. The peak is between 2 to 5, and there is no gender difference as an adult. We have the clinical features, as Dr. Mona mentioned, that they are divided into nocturnal symptoms and diurnal symptoms. On the nocturnal symptoms, we are looking for the snoring, the observed apnea, the snorting, the gasping, choking, restless sleep, diaphoresis, paradoxical chest wall movement, and abnormal sleep position, secondary sleep enuresis. During the day, we look for daytime somnolence, behavioral school problem, difficulty waking up, morning headache, nasal congestion, mouth breathing, all these can be seen. We'll skip this, as Dr. Mona talked about what we can see on the physical examination, and we talked about the anatomy. However, on the Malambati score, I just want to point that when every Malambati point increase on the Malambati score, we have an odds ratio up to 6 times increase, up to 6-fold. Which is make it really important to assess this before going into the sleep study, and you can rearrange your priorities. And for the tonsillar size increase, with each score increase, there is a 2-fold increase, making it more common or more possibly to have a higher apnea-hypopnea index. So how do we diagnose obstructive sleep apnea? Going back into the clinical criteria, one or more of the following, which is include the snoring, labored paradoxical or obstructive sleep apnea, any of the signs that might indicate airway resistance. In addition, we have the polysomnographic criteria, which is including at least or more than one obstructive sleep apnea, mixed apnea or hypopnea, or we have obstructive hypoventilation. And when we have obstructive hypoventilation without the respiratory event noted, we have to look for at least one of the following, which is the signs of upper airway resistance, including snoring, flattening of the inspiratory nasal waveform, and the paradoxical thoracoabdominal motion. The PSG and the details of it, including all of these comprehensive studies already talked about by Dr. Mona. The treatment option is divided into surgical, medical, or orthodontal treatment. Adenotonsillectomy in pediatric is the first line. It is, even if there is a presence of risk factor, it does not cause a contraindication. However, it requires a reassessment post-operatively, as adenotonsillectomy is very common in between the pediatric population. One of the options that's available, and it's what's seen on the chat study, the watchful waiting, which is to wait and see how is the apnea-hypopnea index after 6 months. However, still, when they compared it to adenotonsillectomy, there was a better daytime behavior, sleep apnea symptoms, and subjective sleepiness, and the quality of life was better. It is used only, this approach, in the mild to moderate. In the severe, we don't use the watchful waiting. In addition, while we are doing the watchful waiting, we need to treat any underlying comorbidities with allergic rhinitis, with asthma. We have to give good education about the sleep hygiene and to ensure that the patient comes at 6 months or even sooner if there was any worsening in the symptoms. Okay, so the next step after adenotonsillectomy is the positive airway pressure. Positive airway pressure treatment, as shown here, it stents the airway. And while we are providing the non-invasive ventilation or the non-invasive mesh to keep the airway patent during the study. Dr. Ramona showed you the polysomnography of this before, and then this is one of the real patients that we have. And as you can see, there is respiratory event. And to keep you engaged, I would like to have you participating in this. So I would like to, if you know what type of respiratory event are shown here on this epoch. You can start by doing the poll. I think it appears into your phones or your computers. Okay. So let's see the result, Faisal. Excellent. So obstructive sleep apnea, right. As you can see here, there is a drop in the nasal pressure as there is an obstruction happening. However, because the chest and abdomen continued to be there, so this means that the patient is struggling or trying to breathe. However, because of the resistance, there is no more air is coming. The next slide is another type of respiratory event. And again, we have the question, Faisal. What type of respiratory event shown here? Okay, 10 seconds, let's see the result. Exactly, that's right, central apneas. You can see here how is the chest and abdomen built. There is a flattening also. So that means the patient, although there is no air coming out, the patient was not trying to breathe. So this tells you that it's a central problem rather than an airway obstruction. So because the treatment differs based on this difference. So this is the same patient showing the hypnogram that includes the 24-hour of the night, showing how much this kid is suffering during the night with all of these. Every line in this is a respiratory event. And the green parts are the REM sleep, which is the part of the night where the tone really goes down, making the airway flaps and collapse and causing these desaturation to happen. Whenever these desaturation, which is labeled by the red marking over here, indicating that these are the oxygen is dropping during that night, causing the arousal, causing the respiratory events. This affects the quality of the sleep, leading to all the consequences that we talked about over the night. So what happens is usually we, after the adenotonsillectomy have been tried and did not work, medical treatment trial, and then we do the assessment of the sleep study, we usually go for the non-invasive ventilation or the CPAP. We also see other things other than central and obstructive event. We look at the REM index, the sleep efficiency, the distribution, the stage shift, and the awakening. We look at the quality of the sleep study. which indicates the overall study quality that might be later on represented by the daytime function. For sure, this patient was referred, and he was fitted and initiated on the desensitized and initiated on the non-invasive ventilation. And he have no option as he was fitted by Dip Olmsted, who I can see here attending. Thanks, Dip. And this is the PSG after applying the pressure of CPAP 4. As you can see, the flow is very nice. There is no drop in the oxygen saturation. The abdomen and thorax was simultaneous with no paradoxical movement. And patient even was in REM sleep. So this indicates the success of the CPAP. As you can see in the hypnogram, now all these respiratory events that were here is already gone, with very smooth, and lots of these respiratory desaturations have gone. So the patient will have more consolidated sleep with less awakening, less arousals, and will have better qualities during sleep and more quality of the next day. Okay, we'll shift gear to the insomnia now. In general, insomnia is defined to having difficulty with either initiating, staying, or the number or the quality of the sleep, despite having the adequate opportunity of having the circumstances during the night. In addition, to label it as insomnia, and you need to have that resulting in a daytime impairment, which include any of the daytime symptoms that we talked about, the inattention, the problem with the memory or consolidation, impairment in the performance in school, or like social interactions. What do we have is the chronic insomnia disorder now is the change to be the head category of the sleep, of the insomnia, which is only categorized to acute and chronic. And the frequency, to mention it is chronic. You need to have it at least 3 times per week, more than 3 months, and it never or cannot be explained by other sleep disorder. In children, we used to have the behavioral insomnia of childhood. Now it is a subcategory of the chronic sleep insomnia. It includes the sleep onset association, the limit setting, the mixed type. In the sleep onset association, the child have learned to associate the sleep onset with a circumstance that is usually demanding for the caregiver. So we'll never be able to fall asleep without these circumstances happening. What we do usually is, and then we have the limit setting type, which is the refusal by the child to go to the sleep at the appropriate time of sleep, leading to insufficient and limited sleep time. This is usually explained by the insufficient or limited limit setting in the family. The child might come with lots of explains, like needing drink, leaving lights on or off, needing to tell a story, or whatever reasons that they come with. So it needs more of the behavioral intervention and education to the family, which we get a lot of help from the sleep psychologists who help in the education, allowing the parents to know that the awakening during the night is normal. However, the child should be self-soothing to go back to sleep. New sleep onset association can be taught during the sleep studies. And in addition, having specific behavioral therapies for these types of patients, like the unmodified extension, like the graduated extension, faded bedtime, all these can be used and with a greater success. And this is why really a sleep psychologist is really needed during the sleep. Okay, we'll shift now to the parasomnia in kids. When we talk about parasomnia, we're talking about the state of consciousness. So in general, we are overall in one of the three states of conscious during the day. So the first, when we either in the wake, we either or REM or non-REM. However, we might sometimes get stuck between 2 stages, like between wake and non-REM, or between wake and REM. And this is the cases of the parasomnia, which is the dissociation between the 2 states of consciousness. As Dr. Amina mentioned before, that the first half of the night is mainly non-REM and the second part is REM, which is by which we classify the non-REM and REM-related sleep disorder. non-REM related sleep disorder, which happens between 2 to 10 years, happening in the first half. Usually when we do the EEG, we are talking about slow wave, delta and theta wave activity. Duration usually lasts between 10 to 20 minutes. In the non-REM sleep disorder, we're talking about confusional arousal, sleep terror, and sleepwalking. Why they are important? Because they are look terrifying to the patients, to the family. They affect the quality of the sleep, and they are an indicators of the bad quality of the sleep. I will share with you some of the videos that shows the kids who are having sleep terror. And so children's in deep sleep, when we do EEG, they are in deep sleep. They're not awake, although they might look be awake. They might be interacting, so you might think that they are awake. However, they are in deep sleep, and as you can see, the family really struggle. They usually do not remember these episodes when they wake up, as this is one of the non-REM sleep disorder. Another thing is the sleepwalking. Sleepwalking sometimes might be harmless and might sometimes people think it's funny, but however, there is lots of consequences. As you know, it depends on the type of the dream that he's having. So it poses a significant risk of safety risk based on what he's dreaming about. So here is the higher risk where kids might be leaving the house, might be walking, and it depends on where they are going, and depends on the content of that dream. So it is really frightening to the family and to the parents. So there is general strategies. If this is infrequent and it does not cause significant harm to the patient, then we do not need to treat. However, we need to consider other modalities of treatment. Underlying triggers needs that increasing the arousal needs to be treated like any other sleep disorder. Measures including safety, like putting gates on the bedrooms and locking the doors and windows, putting installation and safety alarms to that is really important. In addition to the anticipating awakening, which we usually 10 to 15 minutes before the usual time where this happened. If you wake up the kid, there is significant improvement in the number and the frequency of these disorders. The REM sleep, also including the nightmare, REM behavioral disorder, and isolated sleep paralysis. Nightmare, as we mentioned, it's an internally generated conscious experience of the dream. It looks like the nightmare. However, we have the kid who is fully alert when we wake them up. They remember it in the next day, they recall it. What is usually causing this in the next day? It's usually the emotional impact. And there are some behavioral techniques like the reassurance, prescription, desensitizations, all can be used to overcome this problem. There is some medication that can be used in extreme cases. This is the isolated sleep paralysis, which is we call the Jathom. In this case, as we mentioned, it's we are sharing some part of the REM sleep and some part of the wakefulness. So what's happening is that the part of the REM sleep is the atonia, which is the loss of the muscle tone in the body. However, the kid or the patient is really awake and aware of what's happening around him. They might have some hallucination part, which is part of the dream content, intruding into the real surrounding of the patient. So it might be really frightening. Basic treatment is usually to improve the sleep hygiene, avoiding of sleep deprivation, and give good reassurance to the family. Some pharmacological interventions are possible, that medications that suppress the amount of the REM sleep. The REM behavioral disorder is the opposite. Now we have the loss of the atonia, however, the patient is dreaming. So what we have is acting of the dream, which is really dangerous now. And this is more common in adults. However, in pediatrics, we have it under 3 categories usually. Patients who have narcolepsy or idiopathic hypersomnia, patients who have pharmacological or agents that usually augment the muscle tone, and then neurodevelopmental patients, which we see a lot during in many genetic disorders. Discontinuation of the medication and assessment of the neurological status, referring to the MRI, is really important, and doing genetic and endocrinological evaluation to make sure that there is no underlying disease. Management is available. We'll not go into details of this. Then we'll, even in the sleep-related movement disorder, it is also one of the things that cause disturbance to the quality of the sleep, which might lead to the overall problem of the sleep quality. We'll not go into details as no much time. We'll talk about the circadian quickly. A circadian rhythm include lots of things like the delayed sleep-wake phase, advanced sleep-wake, irregular sleep-wake cycles, and non-24 hour, the shift work disorder, and jet lag. Dr. Mona showed some of these episodes or with the sleep schedules that they are showing. We'll just be talking about the delayed sleep because this is one of the main things that we see in adolescents especially. As you can see here, the circadian rhythm or the melatonin phase, where the melatonin surge in the normal, however, it is pushed later on during the night or the late at night when in patients who are having delayed circadian sleep time. This resulting in patients who being alert during the evening and very sleepy at the time of wakefulness. Because the time of wakefulness is usually fixed, so the patients will be having difficulty and sleep, leading to insufficient sleep in general. What we do for them is the education, improving sleep hygiene, decreasing the bright light exposure and the use of electronics, timed bright light exposure, and then chronotherapy depending on whether to go forward or backward, depending on the medication. We can set the circadian rhythm also by giving a smaller doses late afternoon to reset the circadian schedule again. Exposure of the early morning bright light might shift back the melatonin surge, which leads to earlier sleep. This is the last part of the disorders in general. This is the hypersomnolence, and it includes lots of details or lots of primary sleep disorder. But in general, for non-sleep, I would like just to share with you this slide that shows whenever you have a daytime sleepiness and you are thinking about this patient, the reason you are looking for to count the total amount of 24-hour sleep time. So if you have a child who is normal, have the total amount of the sleep time is normal, then you might look for underlying sleep disorder because the quality now of the sleep might be affected, leading to looking for another sleep disorder. However, if you find that there is no deficient, there is less time so this means patient is having either problem with difficulty in having insufficient sleep. So you ask about the sleep onset. If there is no problem and the patient is falling asleep easily at the sleep onset, this is usually related to the sleep onset, to insufficient sleep syndrome, which is usually related to social, to work demands. When you have a difficulty in falling asleep and you have a less than normal total sleep time, you ask the patient to delay his sleep onset. If after delaying the sleep onset, you found it's easy to fall asleep, then you're most likely talking about a patient who have a delayed sleep onset. However, if it's still difficult, then you make sure that there is no anxiety involved. If no anxiety, then most likely this is a poor sleep hygiene. If it's associated in anxiety, then you're talking either an anxiety-related insomnia or even psychological referral is needed. And this is an anxiety disorder, a general anxiety disorder. Narcolepsy is one of the primary sleep parasomnias that usually lead because of this deficiency in the hypothalamic hypocretin signaling. It features excessive daytime sleepiness, cataplexy, hypnagogic hallucination, sleep paralysis, and fragmented sleep. Those adolescents who have it usually perceived as lazy and having social, academic, and athletic impairment. So they have academic deterioration usually. On the sleep, when we do a sleep study, we found there's short sleep latency, sleep onset REM. In 50% of them, there is lots of sleep fragmentation. There is lots of limb movement associated. We do the test called multiple sleep latency test, and which allowing the patient to have 5 naps after the overnight sleep study and assess how much of that is having REM associated apnea. We'll not go into the detail of this as it's not relevant. And it shows here how the patients with narcolepsy have significantly less sleep latency compared to normal patients or patients who have other sleep disorder breathing. There is non-pharmacological and pharmacological, including the education, association with other sleep disorders, school, career counseling, and then allowing a strategic napping to help them be refreshed and having their activity again. Pharmacological treatment depends on for the excessive sleepiness and for the cataplexy also. I would like to thank you. This was really short time to talk about all the sleep disorder. However, this is what we can. I would like to thank Dr. Adil for this great initiative. And before we end, I would like to say a few words that in the memory of Dr. Mohammed Albalawi, that اللهم إني أسألك حسن الختام حسن الصيام وحسن الختام ولا تجعلنا من الخاسرين في رمضان. اللهم اجعلنا ممن تدركهم الرحمة ثم المغفرة ثم العتق من النار. هذا في نفس الأوقات هذه من السنة، فأتمنى من الجميع أن يدعي إن شاء الله.
Thank you, Dr. Mohammed, for the very interesting lecture. I think we have some time to answer a few questions. We have Okay. First question by Khalid. She's asking about does consumption of oral melatonin affect the circadian rhythm in the long term? I will answer this. Just to make it clear, melatonin is a normal hormone in the body. It's secreted normally in the brain by the pineal gland, and it, as we mentioned, it helps you in shifting from wakefulness to sleep and to maintain the sleep. Now, a lot of brands and medications are being sold as supplemental melatonin, and they are put even with the multivitamin, like the vitamin section. It can be helpful for short duration. We recommend using them for short duration. If you have problems like insomnia, or if you are traveling from one place to another where there is a difference in the big difference in time, that's what we recommend. Now, using them for long term, as a medication, it's a safe drug. However, keep in mind that giving a hormone that is naturally produced by the body may suppress your natural hormone production. The second thing, melatonin is a hormone that is naturally suppressed during certain stage of our life, like during puberty. They noticed that melatonin levels drop down a little bit. And this was explained because of its inhibitory effect on the gonadotropin releasing hormone. So if you keep on supplying it for long times during this period, it might affect the natural process of going into puberty and make it somehow delayed. So in generally speaking, we recommend short-term use for it, not long-term use. And if we're talking about pediatrics, the main method for treating their insomnia issues and their sleeping problems is behavioral modification, and we use it sometimes as a supplement to help or just to start the process of organizing the sleep, but not for long terms. Dr. Mohammed, if you have any further comments on this question.
No, I think you did great. Thank you.
Okay. Another question we have from Ali Asiri: would you recommend ENT referrals for kids who clinically showed signs and symptoms of OSA without sleep study?
Well, I want to answer that. So for kids who, without doing a sleep study can be really delayed, and it can be, you can gain a lot of, as you mentioned, we are talking even for kids who have the result of showing that moderate to mild diseases, we do not want to wait more than 6 months. If you look at any wait list now, if you have symptoms, that is, we mentioned nighttime or daytime symptoms, please refer to the ENT. And regardless of the age, regardless of the other factors, it is the risk should be taken. If it's a high risk, then we should monitor the patient post-operatively. But I really encourage referral for patients, especially when we are talking about obstructive sleep apnea. We should not be letting the patient waiting only for that. I really encourage having the adenotonsillectomy seen and done based on the symptoms. I know the recommendation is saying to do a sleep study, but whenever feasible, we can substitute that by doing oximetry or doing any with a capnography, but however, we should not delay the surgery.
Okay. For me, I just want to add maybe I agree with Dr. Mohammed. The adenotonsillectomy is the main stem of our management, especially if you have, mainly if you have adenotonsillar hypertrophy. But sleep study would be really of importance, mainly in the children who have other risk factors, like in obese children or hypotonic, or you expect residual OSA. It's very important to have it, also to assess the risk to go for surgery to start with. So I think it's case by case, but yeah, in normal children, especially if you have limited resources, I think you can just refer them. Okay, next question. Why neck examination is important? After, I think, as Dr. Mohammed mentioned, you see the airway, anything that blocks the airway will cause major consequences on the sleep, especially when you're sleeping. So if then, of course, the airway passes through the neck. So neck examination is important, like in children with Down syndrome, when they have short neck. This means they have short airway and it's more crowding in that area. If there's also any masses in the neck, it might also compress and narrow the airway further. Another thing also, if you have spasticity, and we see this in patients mainly with cerebral palsy, sometimes they come with OSA symptoms and they don't have, for example, enlarged tonsils or adenoid, or they don't improve completely after that. And we noticed that once you give them like baclofen or anything that releases the spasticity of the muscle, the airway improves, because this stiff muscle compresses on the airway, especially when they're sleeping. So it's important to see anything that will affect the airway. That's why it's important to examine the neck. Okay. We have a question from Tamer. Is it okay if I want to ask about TNA as a first-line treatment? What is your opinion about TNA in hypotonic kids, for example, Prader-Willi, if they have high AHI, keeping in mind theories speaking about tonsils being supporter for the base of the tongue? Would you like to answer that, Dr. Mohammed?
Yes, okay. So I think Dr. Tamer is talking about how is the tonsils usually and the adenoid supporting the airway, giving the tone, especially when we don't have a central control of the airway. So this is the cases that we need to have the sleep study done, neuromuscular disorder, and then assess how much of it is related to central drive, how much of it is related to the airway, and whether there is an associated hypoventilation. Because it depends whether we're going to the CPAP versus BiPAP, and then it depends also if we are going, if the significance or the amount of the airway obstruction is mainly the cause that is developing or fastening the hypoventilation, then we would want to operate and we would even go to the hypoventilation. There is, I mean, if we even go to the part where we lost that support, which is eventually will happen with any neuromuscular, then we have the other option of non-invasive ventilation. So we should not deprive them from the treatment or relieving the airway because we cannot, because we have other treatment that's available. So yes, I would support, but however, this is the cases where I want to free my beds in the sleep lab to do those for such patients.
Okay, thank you, Dr. Mohammed. Another question, what is your thought about using stop-bank questionnaire on pediatric patients? Stop bank questionnaire, it's like a screening tool for the obstructive sleep apnea. I think our gold standard is to go with the sleep study if you have it. I mean, you can, like, if you want to screen it by symptoms and sign, that's fine. It gives you an idea, but I wouldn't depend on it to decide that this is moderate or severe or low. No, I would still go with the sleep study as the gold standard. And based on the result of the sleep study, I would decide my management. Plus, it has limitation, does not tell you about the hypoventilation, does not tell you about the central. It's mainly screening mainly for the obstructive part. Dr. Mohammed, or your...
Yes, agree.
Okay. A question: how to improve sleep hygiene in pediatrics? Would you like to answer, Dr. Mohammed, or I should go ahead?
Go ahead.
Okay, so sleep hygiene, basically, it's most of it, it's behavioral modifications. By sleep hygiene, I mean, make sure that the child go from the environment that the child is sleeping in. Make sure that the room is optimal, it's comfortable, the bed. Sometimes you have to go to the details, the mattress, the pillow, the texture, is it comfortable or not? The temperature, is the room too cold or too hot? I mean, go over the environment as a general. If the child is scared at night, you can just keep a light open or night light, or keep the door open. If the house is noisy, you should try to decrease this interruptions. The other thing, the child behavior himself and what he eats, what he drinks. Like, we don't encourage that children eat a lot of caffeinated food, like sodas or cola and chocolates at the evening time, because it will make more stimulation. So anything that has any caffeinated substances, to make them earlier in the day, avoid them at night. Avoid also excessive activity. If they want to, like, if you have many children, they want to play before bedtime, it should not be like aggressive jumping and running and going around. It should be something calm, like coloring books or reading something, or board games and such on. The other very important part of the sleep hygiene is the use of the bedroom. By this, I mean the bedroom should we always encourage that the bedroom should not be used except for sleeping. Some children we see, especially the bed, they sleep, they eat on their beds, they study on their beds, they play on their beds. This is wrong, because it makes an association between the bed and the activity that they're doing. So we always encourage that use the bed only for sleeping. Use the bedroom in general, try to make it only for sleeping. So we have better association between the child and the bedroom. And many advice we can give. This is why it's important to assess the environment and the whole story. And based on that, we pick up the problems in each child, and we try to advise accordingly. So it's mainly behavioral things, eating issues, how they use their bed, their bedroom, and so on. Okay, is there an age limit to decide what type sleep of study to describe?
I think she's talking maybe about the MSLT versus the overnight.
Maybe, yeah. Mm-hmm.
Yeah, so in general, sleep studies can be done to any age. Now we're talking even about neonatal sleep studies have been done. But some of the studies that requires the interaction and communication, like the multiple sleep latency test, which is usually can be describing the narcolepsies, which diseases also can result in can come in later age. Usually, we do not do it unless the patient is more than 7 to interact and ask him to go and wait for 2 hours and they come back. So, however, the overnight sleep study, it can be done for any age.
Okay.
Yeah, but she corrected that. Oh, he corrected it. Yeah, he meant full sleep, full PS3. Exactly. For the level 3 or the home studies, we do not have any evidence for them, especially in children. It can be really underestimating the severity of the sleep apnea. And it's not recommended. For any pediatric patient, we should do the full night, as even the sleep staging in pediatric is different than adult. It mainly depends on the behavior. So you need to look at the camera, you need to see the patient, what is the patient is doing to decide what sleep stage is that. So level or like home studies are not in kids yet.
Okay, last question. Where can you do sleep medicine fellowship, duration of fellowship? Usually it's 1 to 2 years, depending on if you're going for, okay, I have a comment at the Saudi Pediatric Association. Go ahead, please. You can answer the question.
That's okay for you, Doctor. Go ahead.
So usually it's 1 to 2 years, depending on the if you're doing it purely clinical or research and so on. What I know I don't know if you're asking about Saudi Arabia. In Saudi Arabia, we have in the King Saud University Medical City, we have a local sleep fellowship mainly for adults. That's what I'm not sure about any other programs in Saudi Arabia. Abroad, of course, there are a lot of programs in US, in Canada, in different areas. I don't know if I answered properly. I don't know if what's the exact question, but this is, if you're asking locally, we have one in Riyadh. Any comment, Dr. Mohammed?
No, I think you answered it, yeah.
Muscular disorders. Dr. Mohammed talked about neuromuscular disorders and with central sleep apnea and hypoventilation in pediatric with neuromuscular disorders such as muscular dystrophy. What is the preferred mode of treatment?
Okay, so it depends on what you see on the sleep study. Being a neuromuscular patient does not mean that you are not allowed to have obstructive events alone, so can be treated with a CPAP only. However, many of the neuromuscular, later on, they go to the stage where they develop the hypotonia that they need some assistance into their muscles to ventilate. So we shift to other type or modalities of ventilation, including the BiPAP, and depending on the severity of the underlying disease. Also, surgery should be thought of initially if this is like an early stage of the disease. It's an only obstructive medical treatment. They are allowed to have allergic rhinitis. They are allowed to have asthma, and you need to tackle all these together. However, if you're talking what specifically for neuromuscular, usually we're talking about control or central control of breathing, where we need to give them the stimulus to breathe or the support for their muscles to take a deeper breath so they do not hypoventilate.
I agree with you, Dr. Mohammed. Maybe one comment for the neuromuscular. If you're taking care of neuromuscular patients, the most important step, I think, is to pick them up before they start having symptoms. So always consider once you have this diagnosis at baseline, once they are diagnosed, you have to have baseline study, and then just do regular sleep studies, especially when they start, as Dr. Mohammed mentioned, showing the hypotonia and becoming wheelchair ridden and so on. Because the problem starts while they're sleeping, and then they start manifesting while they're awake. So if you wait until they come to you with symptoms, this means you're late. So I think in general, our role is to pick them up early on, to help them early on and decrease the consequences and the problems, help them to have better quality of life. Okay, I think we're done with the questions by this. Thank you very much, everyone. I hope it was informative and you enjoyed our talk. يعطيكم العافية جميعا.